It's already recording. Nice. All right. Well, welcome everybody to September Idea. Again, what happens is people like submit ideas, like just happened a few minutes ago, about, hey, wouldn't this be a great topic for us to kind of think about and learn more about, invite some experts in to talk about, in addition to the listserv that we have. So one of the things that came up, there's several different kind of new tools out there that have been getting a lot of press, making a lot of headway. And we thought it was time to invite some of the speakers in from those different places to say, what is this tool? How does it work? So today is Canvas Dx, which is Cognoa and NODA. And then next month, we actually have another whole group coming in too, that are two more different ones that are kind of these diagnostic aids and screening tools that are coming out. So, and then we have some ideas for the months after that. So my quick introduction to this, and then I'll pass it over. I'll have Cognoa talk first and then NODA. Is I have to admit a certain hypocrisy around this, I guess is the best way to think about it. I love technology. I have 3 or 4 grants here that are exploring the use of technology in improving the screening and diagnostic processes. I honestly think, and I'm a huge believer in, this is the future. This is the future of the field. This is the future we're moving into. As technology develops and increases and improves, it's just going to get better. And we have to learn how to leverage technology appropriately in a way that improves our ability to diagnose, screen, and treat and intervene with these patients. There's so many exciting different technological advances that are helping us do this. That's one side of it. I know there's a tension that I have too, because we have so many wait lists, right? So like all of us have wait lists that are huge. So we want to be able to do stuff that improves the throughput for our kids and our families that we see. The hypocrisy side comes in. Summer Bishop and I have actually written articles on, like, well, let's be cautious though. Let's make sure that when we do this, we do it in the correct way. There's lots of, like in our field, there's so many startups out there that make all these claims. We've all experienced this, like this can cure this, this, and this, this, whatever it is. And we just want to be really careful. Our families and autism especially have been through a lot with regard to the snake oil side of it. And we as clinicians have to be very careful about, claims of a company are different than what happens in the real world. And we want to make sure that the claims are accurate. And the other caution is misuse. We want to make sure that the tools that are out there, you can have the best MRI machine in the world that's so accurate, but if you don't have the right clinician or whatever expert reading the MRI, it doesn't really help. So we want to make sure that these tools that we're developing are used in a way that are appropriate in the field. So that's where my hypocrisy, that's why I'm super excited that the people have come today to help us learn more about both Cognoa and NODA, and teach us about their tool, what it does, what it can do, and I'm very excited to hear from them. So I will let Sharief, I'll pass it over to you, and I'll let you introduce yourself and your folks, okay?
Great. So my name is Sharief Taraman. I am a pediatric neurologist by training. I have a second board certification in clinical informatics. I'm the chief medical officer at Cognoa. I do also wear some other hats, so I do have my affiliations listed, but for the sake of time, we won't go through all the million things that I do. I am joined by a child and adolescent psychiatrist, Dr. Jennifer Shannon, as well as one of our excellent medical affairs colleagues, Dr. Tobin Chetia. He's a PharmD, who is our VP of Med Affairs. So if this will work, let's see. I got a PowerPoint. Does that look good? Fantastic. And I think Steve made a really good point, which is, I have one of my mentors who works in the AI space, and, there is a lot of hype in AI and technology. And the reality is that these things are not replacements for us as clinicians. They never will be. And I think anybody who kind of comes and says, oh, radiologist is going to get replaced by an AI reading tool is, woefully mistaken. But the reality is that we are inundated and we have lots of shortages of specialists, including things like radiology. So if you have a tool that can help you identify abnormalities and make you a more efficient practitioner, or help kind of with things like missed diagnoses, I think that there is an opportunity for that technology to really make a huge difference. So for those of you who don't know who we were founded back in 2013. The initial work came out of Dr. Dennis Wall. He is a biostatistician that was at Harvard at the time. He was looking at the genetic markers for autism using AI-based tools, specifically this thing called machine learning. And he was, shadowing clinicians and looking at, like, how do we diagnose autism? And he kind of identified like there's an opportunity to potentially make this more efficient, as well as maybe get additional information in the way that we look at autism by applying some of these machine learning tool principles. And so that started his work. He had made a jump over to Stanford, I think in 2014 or 15 at the time. And then the company was founded and sort of grew in that. I've been with them for about 6 years, and really my focus has been, this is obviously cool technology, but how do we apply it in a medical setting? How do we actually go through and complete out the clinical trials that our dear colleague Clara Lajean-Cher had started, and as Steve mentioned before, some of you came on, he, Laura Carpenter, and Zach Warren were actually our amazing partners early on when we were first developing the tool, kind of as a screener. But it has significantly evolved. We are now market authorized as Canvas Dx. And one of the things that we're looking at is can we look at applying this technology to then also guide the pipeline? And these are some of the things that we've been looking at our pipeline. So the whole point of this is really to try and streamline the diagnostic journey. And my motivator for coming into Cognoa is, I was seeing patients in my clinical practice. I'm the former division chief over at Children's Health of Orange County and UC Irvine pediatric neurology. And, kids were coming into the clinic and I'm looking at their chart and I'm going, oh my gosh, nobody screened this child. The parents were reporting challenges. They finally got to come in for a developmental evaluation, but, we missed that boat because we weren't doing what we were supposed to be doing. We're not really following our guidelines. And that's not a dig on pediatricians. The reality is, I don't know if you saw that recently, there was an article that came out that said, if you wanted to do all your screenings and all your guidelines for chronic disease management, you'd need 27 hours a day. And guess what? We only have 24. And that doesn't leave time for even charting. And all of us are, sitting at night watching the computer and charting while our family's watching whatever TV show. My kid's watching The Good Place now. That's her favorite. Okay. I don't know if it's appropriate for her, but I'm busy charting. So I think we all face this reality, though. We have sort of unfortunately created this really hard thing for parents to get their kids evaluated and diagnosed for autism. In the past 20 years that I've been in practice in the medical field, we've not seen that average age of diagnosis really move the needle. We're losing, I think, time where we could be really intervening. And yeah, you don't need an autism diagnosis to intervene, but the reality is that we're not doing it like we should. And so when we have continued sex biases, race, ethnicity biases, socioeconomic biases, right? Like these things have gotten a little bit better. And I think people are hyper aware of them, but we really haven't made big differences. So these are all the things that, keep me up at night. And I think about, okay, can we use technology to try and address some of them, realizing they're complex, but maybe you can't do everything. And then I don't need to tell you all, but this is the sort of current diagnostic pathway. We have a concern. We go through, maybe some screening. We get to a specialty care setting, but we've all got these wait lists. We've all got long wait times. There's a shortage of referrals or specialists to do the evaluations. And so is there a way that we can do some shifting of that care into the primary care space, and or potentially help us as specialists figure out how to maybe triage better, or how do we utilize our resources better? And so can we think about maybe alternative diagnostic models or ways that we can do things even like telemedicine? I think all of us were kind of suddenly, shocked. Okay, well, how do we do an autism evaluation when there's a pandemic and maybe these patients can't come? Steve has done a lot of work when he was back in Missouri for like telehealth models, because you have patients that are in these really rural communities, and how do you get them to you when they have to travel 100 miles and they're a single parent who works 2 jobs? Like it's really hard for these parents to get in. And so are there things that we can do where we apply remote technology or whatever to try and help with the diagnostic process? So what Canvas Dx is an AI machine learning tool. Again, AI has kind of come a long way. There's things like computer vision, speech recognition, NLP, things that I don't need to bore you on. But the reality is that there is this, technology out there that could be useful. And so we think about software-based approaches to overcome some of these barriers, improve, how we evaluate children with autism. So really we think about Canvas Dx positioned sort of in this in-between space. We know that screening happens in the primary care setting. We know that we can diagnose in the specialty care setting, but can we aid in the diagnosis in a primary care setting and or with specialists, maybe in collaboration model with the primary care physicians, like we've done, in ECHO as an example, to really help, move the needle and be more efficient in how we get these kids into services when it's appropriate. So what we've done is we've tried to, collect information in an efficient manner. So there is a caregiver input. It's 18 to 21 items. These were selected using machine learning techniques to find the maximally predictive features of autism that we could obtain through a caregiver questionnaire. There is a video input where the parents will actually upload at least two videos of their children, a few minutes in length, so not super long. It takes the parents about 11 minutes to kind of do that process is what we captured. Those videos are then actually scored. There's a 28 or 33 item questionnaire, depending on the age, where the video analysts are trained master's level, ABA, PT, OT, et cetera. They score these questionnaires. And then the physician who prescribed the device or says, hey, can you do this for me, to one of their colleagues, does 13 or 15 item questions after they've evaluated the child. And those are, again, developmental questions that are maximally predictive of autism. And then the AI algorithm, the nice thing about it is because the heterogeneous nature of autism and the way it presents, it uses a mathematical vector. So we know that not every child with autism presents the same. And the nice thing about looking at all of these different, independent items is you can kind of see patterns of behavior that kind of come forward. And then the device itself will give a positive, negative, or I don't know, or what we call indeterminate result. And the indeterminate result is a safety feature, because what we don't want to do is falsely label a child with autism or not autism. And so when that device is not sure, it doesn't have enough information, that indeterminate, that no result, whatever you want to call it, abstention category is really to protect kids from getting misdiagnosed by the clinician. And then all of the inputs are available for the clinician to review. So what did the parents answer? What were the videos? What did I answer as a clinician? So I can see that collective information and then use that with the history that I've taken to actually make a diagnosis and obviously my observation. So we did a clinical study. We recruited 425 kids across the United States. The study population mirrored the US population. And what we did is everyone was evaluated by Canvas Dx. The result of that was blinded to everybody, including the patients. Then every patient went and saw a specialist who diagnosed, autism using standard measures. Those included at least 5 years experience, had to be board certified, 5 years experience in autism. Most of them had, 20, 30, 40 years of experience. But they included developmental pediatricians, neuropsychologists or psychologists, pediatric neurologists, and child adolescent psychiatrists, but that actually do the diagnosis. And then ultimately, everything was, they had to map it to DSM-5 and they had to meet full criteria. And then what we did is we videotaped a portion of the, so we took all of the history and physical documents, but obviously excluded the diagnosis. We took video samples of the interactions of the practitioner who was evaluating the child, and then those were reviewed by a central panelist who was also a specialist. And then they would blinded independently determine if the child met DSM-5 criteria for autism. If there was disagreement, it would go to a third central review panelist to serve as a tiebreaker, which happened about 20% of the time, which is not actually uncommon when we're doing a very robust reference standard to try and determine, does this child have autism or not? There's about a 20% disagreement rate that occurs in the real world. And then we recruited a sample that was pretty diverse. We really tried and get something that looked like the US Census data. Interestingly enough, we did have a slightly higher parental education than the US Census data. Again, not uncommon for clinical trials. But the interesting thing here was also the household income was actually lower than the US national average for our trial. But if you think about it, these are parents who probably have a child with a significant neurodevelopmental disorder, and they probably cannot actively work as much in the workforce. And so you have probably a shift, even though you're more educated, maybe one or more of the parents is unable to work as much in the workforce. And so their household income actually is decreased as compared to the US Census data. So we submitted that to the FDA for review. This was the first FDA market authorized device to aid in the diagnosis of autism. So it was a de novo application is what it's called. We have to go through all of the things that you have to do to make sure that it's safe, effective, and then also, have all of the security protocols in place. So to me, that was a really important milestone to actually get it through and take it to the FDA for review. Because I think, as Steve was mentioning, there's a lot of stuff that's kind of out there in the world where there's kind of like crazy claims and nobody really is looking at it to say, is this real or not? We do have the benefit of being able to continuously try and improve the device. And so the more data that we get, the better the algorithm performs. So these are current performance metrics. So our NPV is approximately 96%. The PPV is approximately 98%. I have the confidence intervals in there. And then this is also on our website. About a third of kids are not going to get a result. The device is not able to make a determination. And then the sensitivity and specificity within that determinant cohort is listed there at 85 and 96% respectively. And again, this is important because this is not meant to be a standalone. The clinician does need to weigh in and say, I actually agree and this child does meet DSM-5 criteria, but at least they can be, pretty confident if it says that it's not, it's probably not autism. But again, our advice to the clinicians is, if you disagree with that, please still send them. Please, don't just rely on the device, because we all know that every test has its limitations. And similarly on the PPV, right? If it's positive, they still need to meet that DSM-5 criteria. And then again, that doesn't mean that you're done. It just means you've helped establish the criteria so that they can start getting into treatment. Forgive me for the formatting of the slide. Some of it got a little bit messed up, but if you think about a potential diagnostic pathway that's streamlined, then I'll be done in like a minute. If you have a risk for developmental delay, they can go to their primary care physician. The American Academy of Pediatrics clinical report does encourage clinicians that if they're familiar with DSM-5 criteria and they can do an assessment, to try and make the diagnosis so we can try and get those kids into early interventions. And then again, they have the decision as clinicians to think about, do I want to consult with a specialist like in a psychiatry collaborative or in an echo model so I can address all of the things that happen and all the comorbidities that we know happens in autism. Specialty referrals still may be totally appropriate, and it's not necessarily to say we don't want to refer the specialist, but then as specialists, we can actually triage a little bit better, and then we can decide, what does this child actually need for us to move them forward and get them what they actually need in terms of care, and who can wait and who can't wait, because unfortunately we are in a triage type situation. So key takeaways, I think we all know that the diagnostic pathway currently is challenging for families. If we can apply data-driven approaches, if we can use technology to help healthcare providers, make more efficient, more accurate diagnoses in a primary care setting, I think that that's very helpful. We do have the market authorization from the FDA. It's the first of its kind to do that. The age range is 18 to 72 months, and they do need to have a concern for developmental delay that's been expressed by either the parent or the clinician. We have our clinical trial data. We're always looking to do more clinical trial data. We currently have a protocol that we're doing with the Thompson Autism Center in Missouri. It's an ECHO project. We're looking to do some more real world studies of the device. And then we're always trying to make that determinant rate better. We're always trying to make our PPV and NPV better. And the beauty of this is, again, the more information that we get, the more trials that we run, we can update the algorithm to continually be helpful. And then just to flash it, briefly, and again, it's available online. These are the actual indications of use, contraindications, and then these are our precautions and warnings, which are important, and you should read them. Things like the patient has to have some functional capability of English. We do have a desire to move it in other languages, but at the time, this was what we were able to get done. So I appreciate you all very, very much for your time, and I will defer back to the group, and then maybe we'll do questions answered in the chat.
Yeah, no, that was fantastic. A lot of information in the exact amount of time, so very good. Just one quick comment. So group, if you want to start, if you have questions, you can type them in the chat. But otherwise, we can move along to Ron and have him, and then maybe combine the presentation at the end. one quick comment that I appreciate about Cognoa's approach is, as a clinician, we kind of do this too, where it's like you have the ends of the distribution of a diagnostic presentation. It's like, we're sure they're not, we're sure they are, and then where's the lump in the middle? So, you know, it sounds like Cognoa has approach now that you're evaluating a child, they end up in one of these. You hope as you get better and more accurate that you reduce that indeterminate. But the question is, so your metrics are associated with yeah, this is the stuff we can make, you know, a claim about. But I think that's really helpful for a screener and a diagnostic aid that you guys do. So that's kind of a cool approach. Okay, so Ron, over to you.
Thank you, Stephen. Can you see my slides?
Yes, I can. And now they're in the right mode. So yeah.
Wonderful. Thank you for inviting us to this forum here, and my compliments to the Cognoa team for an excellent presentation and what they're doing to help push the field forward in options for diagnosis. And we learn a lot from what Cognoa is doing ourselves. I know I'll forget so many people to thank, as far as folks on this call and everybody who's influenced us to where we are right now. So I won't even try, but just know that we thank you. What I want to do in my 20 minutes is give you the backstory of kind of what is the history of what formed this NODA platform. Then talk about the actual product itself and what it's doing to facilitate the diagnostic assessments. And I'll reiterate that these are tools for the experienced diagnostic clinician. NODA will not help tell somebody what autism is. We rely on the clinical judgment of experts for various reasons, and I'll get into that. And then I want to let you know the future directions for this platform and get your input, maybe not now, but forthcoming, to say, how does this support your professional career trajectory itself? So start with the backstory. I come from the medical device industry, and I led product development for leading medical device companies. And in the 90s, we were making tools for surgeons to plan how they were going to get tumors out of the brain, how they could support other surgeries that would be done remotely through image-guided surgery, and also use of telemedicine to be able to guide pre-op and post-operative surgeries in a way that didn't require the doctor always to be present. At the same time, my third son had what many families go through, and that was a healthy 1-year-old starting regressing in his skills. My wife and I ended up going to at least 5 different health professionals over the next 18 months, thousands of miles of travel to finally get a diagnosis at 3.5 years. And mostly because of the contacts we had. It would have been a lot later if we did not have contacts. And ever since, we've been trying to get our son access to services. He'd be considered on a severe autism scale now, profoundly autistic. He's a wonderful 29-year-old man now, and inspiring us to do more for this community. Back in 2001 to 2005, we used my technology background, came up with certain platforms that were helping share to the community what web technology could do to help family find resources and talk autism, and how a disaster relief operation could be conducted through Autism Cares. So we were experimenting with technology to increase access to services. But what always kind of got me impassioned about our own trial is we've always had to try to convey in the right way what our son's issues were, that brief time we were able to see that health professional. And at the same time, other industries in the medical field were just revolutionizing what they were able to do to treat patients when they had an imaging modality and then the use of telehealth. So in the case of radiology, it was only 20 years ago where radiologists would need to go into their hospital, into the radiology room, put their x-rays or images up on a panel and be able to make a diagnosis that way. With teleradiology starting in the 90s, the hospitals were able to send that image maybe to the radiologist, but even to other radiologists who were experts in that specific field of trauma or maybe tumor recognition or things like that. And the field transformed to not just be teleradiology. Now we call that kind of field radiology. Several other fields that I'm showing here, and then beyond that, dentistry and all that, are really showing how care can be advanced when you use this kind of imaging in a telehealth platform. We never could see it happening when our kids were very young, that there was a similar imaging platform. And so we have come up with a platform we call behavior imaging, and there are several use cases that have product names. The diagnostic product that we'll be talking about today is called NODA. But the early days, we were doing as a nonprofit pilot studies with some of the autism clinics around the country on various things. And we were demonstrating that if you could take an image and send it to a doctor for your child's health concern, you could get a faster guidance for treatment of that child. Behavior concerns were also ones that we could get remote guidance in a fraction of the time. But on the right-hand side here, I want to draw your attention, in the early 2000s, we were working with some autism clinics to say, couldn't families give information about their child's inability by sending data, video data in it from home? And this is just an excerpt of showing my wife and my son, Robbie, following the Denver 2 training manual to say, what would we share? And 10 families did similar kind of captures, and we shared it with the autism clinics, and they saw clinically relevant data they were able to make some conclusions on. From that point, we got an SBIR grant, our first one, in collaboration with Georgia Tech and Emory, and we came up with the first asynchronous autism telehealth platform. Asynchronous telehealth was something I always thought was missing in our field, the ability to capture naturalistic data of what somebody's health looked like, typically on video, but it could be done other places, send it to a professional, number two, who have a suite of tools they could use to analyze that video, and then be able to have some sort of report or some sort of direction from that point. One of our partners, SARC out of Phoenix, Arizona, we're doing an early intervention project with that platform. And while the videos from families who were learning early intervention techniques were sent back into the interventionists at SARC, the diagnostic team was kind of overlooking the shoulder of these videos coming in and said they could see the atypical symptoms very clearly, and suggested mapping what they observed in their clinical judgment to DSM-4 at that time, domain criteria, as a way of saying, what is the evidence that we've observed for diagnostic assessments? And that was the genesis of what was important to have a contribution for diagnostic assessment for autism. We got another series of SBIR grants, and thank you to the NIH for believing in this kind of approach. And we compared what would be seen as kind of today's standard of care that takes a long time, and there are a lot of starts and stops along the way. And even by the time we know somebody should be assessed, we all know about the waiting list to get to the specialty diagnostic clinic. We can definitely impact that time period a lot earlier by using a telehealth method like NODA to provide a diagnostic opinion from a experienced diagnostic clinician. And I'll just refer, there are validity studies and time study published on the use of NODA I'll invite you to go to a link I'll share with you at the end to see the research behind that. But what the NODA platform has been up until the pandemic started was a way that families could follow a diagnostic clinic's instructions for what kind of video samples to send. And it starts with 40 minutes of video, but the clinician is also able to text the family through the app if they want additional video requirement. So, and so that's in the home. The families are collecting that data as well as providing a developmental history questionnaire. And then the clinicians themselves have a radiology suite of behavior videos and developmental history they are able to review and that they are able to analyze in terms of a DSM-5 checklist and issue a report based on that. And this was an all asynchronous model at that time. We expected, families to use video conference with clinicians to get the findings, but that was outside of the NODA process up through the pandemic. The important part for the NODA clinicians is that we value your clinical expertise and give you the tools for you to really document your observation of atypical and typical behavior. It tends to be reviewing video, but it also can be reviewing documents or assessments from other sources, for example, or even in the future might be things like Fitbit data or sleep study results, things like that. A unique feature is that there is a coding schema alongside the NODA viewer that this NODA diagnostic viewer is taken from the CDC ADDM coding schematic terminology. So that requires clinical experience to know within subdomains of autism what specifically clinicians are observing in that video, both for atypical and then typical behavior as well. And then what is really elegant, and we want you to really see this as an opportunity to be the diagnostic assessment experts for not only the case that you're diagnosing right now, but having the benchmark data for what happens to that child afterwards. But what the DSM-5 checklist would provide you is whatever you as a clinician have tagged in the videos or developmental history can show up as data and evidence for yourself in your DSM-5 checklist. If you wanted to, these would be the videos right at the timestamp that your team has analyzed those videos to show these atypical behaviors if you wanted to revisit them. And your tagging activity will be tabulated so you can get appreciation for severity or how prominent is this issue. And then there's a general export report capability that makes the report writing that much quicker. Pre-COVID, this is the general process one would go through. We don't want to spend too much time on that. But I want to show you during COVID, we were recipients of another grant to take real-time telehealth and other technology capacity and give the clinician even more tools to be able to do their full assessments. And this is what our real-time telehealth tool looks like during a video conference. And this is what a family's perspective of it would be.
Your diagnostic clinic may use a new tool during their video chat with your family. This tool allows clinicians who interact with you to archive portions of the video conference in their own diagnostic record of your child and may include portions of the recorded video from this conference. This video will be stored securely in the clinic's health records, and this video archive can always be deleted if you prefer and will never be shared without your consent. It will help your clinician do a better assessment of behaviors you talk about or that they observe.
And this would be a clinician's view, and this is actually the clinician seeing a family. When they're doing a video conference, they can be tagging just a certain observations of DSM criteria or typical behaviors that get added to the DSM-5 checklist record. Here for the video conference dialogue they might have had with families. And then separately, if they were reviewing third-party assessments, anything from an MChat screener to Vineland or ABAS or other tools that you use, those documents could also be tagged in DSM-5 checklist, showing evidence of where you've made your clinical decision of atypical behavior for this child. And with those added tools, the clinical workflow can be fully remote for, and it has been through the pandemic, and even now post-pandemic, many clinicians are still continuing to kind of use just a total telehealth approach for their through the children. And this just will appreciate that NODA is always a critical piece to be able to collect that atypical behavior examples, share from families. But then some of the other assessments you're used to using can be done either by the psychologist or neurologist or child psychiatrist, and that, or technicians that your clinic trains. NODA supports a distributed workflow process for multiple people on your team to be involved with the diagnostic assessment process. And our future directions are to make this proven and valid for older age individuals, which will rely more on the BI Live use of our technology to be able to interact with clinicians, and not just for maybe an autism diagnosis, but maybe the common comorbidities, things like ADHD, social anxiety, and depression, that a clinician can just go from one screen to another to be able to do presses and different types of assessments to be able to help someone with a full diagnostic assessment in their older ages, which we at our company get calls from older folks who want to get diagnosed in a telehealth type way, and I understand why that may be. This will be a tool that really will make that very easy. For treatment, that diagnostic record and the DSM-5 checklist could really help the intervention folks that you all support and maybe interact with have a baseline to compare, so we can use that data to be able to do progress assessments, med management for for doctors to kind of say what's helping, what's not, and use this platform in collaborative care where primary care docs can get input from the diagnostic doctors, the psychiatrists, and so on. And we value also this this power of AI for what NODA is as well. We have the largest clinical database of clinically tagged child behavior at time points on video that AI could really, it has already proven to find quicker ways for clinicians to find places that they should analyze first in childhood assessments, saving valuable clinician time. We see this is where we see AI helping your industry going forward to make decisions for yourself either more robustly or get to the parts of the clinical data that you're most interested in seeing to make more informed decisions. And these QR codes here are connections either to the research that we've been doing, current research project that we're currently undergoing, that we're connecting pediatrician clinics to specialty clinics with the NODA enhanced technology that I was illustrating. We also invite clinicians to write and inquire with us so that we can add you to a international diagnostic directory that are serving patients through telehealth. NODA has been used in several countries at this point, translated into 4 different languages thus far. And the DSM-5 checklist could be all, routed to be an ICD 11 or 12, whatever that standard is, if that's important for our international clinicians as well. And at that, I'll leave it for questions or comments, and I thank you for your attention.
Thanks. Can you go ahead and unshare your screen for us there?
Sure.
Thanks. And yeah, we have 15 minutes for questions. I'll start. So my overall sense of this, whereas, you know, Canvas DX is more of a diagnostic tool and aid that has specific metrics around it. Ron, am I understanding correctly that the NODA is more of a platform that's designed to help clinicians, whatever, with the tools that you have available within it, to come to a diagnostic assessment answer? Am I understanding that correctly?
Yeah, it is a telehealth platform that clinicians can use that helps them organize the data that comes in from families to make a quicker, more informed decision for their diagnostic assessment.
Perfect, thanks. Again, very, very impressive. I think, you know, go ahead and raise your hand on the Zoom if you have a question, that we can unmute you, or you can unmute yourself and ask the question either to the Cognoa folks or to Ron for NODA. Yeah, I think more and more people are moving into this space too. I mean, bigger companies, lesser companies. So it's nice that you guys have kind of like got a jump start on that and have developed so much information and research already to help guide the way. I think my dream, you know, like, and again, feel free to other people to ask questions, but my dream is there is something different, having done the telehealth, telemedicine appointments and watching videos, you know, for a long, long time versus live. There's something different live versus a video. There's no doubt about that, right? But I think, you know, what I'm trying to disrupt my thinking is it's not always a bad thing, right? There's always like, it's not always in person is better. What I would love, and what Ron, I saw a hint of with your stuff, is like, wouldn't it be cool? This is my dream, to do like a telehealth assessment that has the tools, perhaps that Cognoa has helped us with the metrics, but then off on the like little corner down here, as I'm a clinician working with a patient, the AI is operating in the background, like doing things like eye contact, eye movements, facial expressions, you know, whatever it analyzes in the background that leverages the technology that has its own metrics associated with it that allow me, you know, this is the advantage of the video. What are the strengths of video and Zoom that we can leverage to help our diagnostic decision making, to balance what we're losing in person? That's kind of my dream, if you will. So,
yeah, Steve, I think that's a really good point. You know, one of the things that, you know, I like, there's a quote from Anthony Chang, who's you know, a pediatric cardiologist in the space of AI, and he says, you know, AI has the ability to make the visible invisible and the invisible visible. And what we see is, you know, there are a lot of things that, you know, we do in medicine. I mean, if you think about how we've set up our clinician rooms sometimes, right? We've got this computer and it's in between us and the patient, and that disengages the patient, right? We see that. And children may act different in a clinical setting versus non-clinical setting. So if you have this opportunity to kind of see both the clinical and what are they doing at home, there's a lot of insights that you can grab. So that's sort of taking the visible and making it invisible. On the flip side, you know, one of the cool things that happened with the AI tools that were looking at diabetic retinopathy was, it wasn't that they could diagnose diabetic retinopathy or pick it up necessarily, but they actually were able to start seeing that there are biological sex differences if you're XY versus XX on the retina. And that opened up the world to ophthalmologists to start going, oh my gosh, there's something that we didn't realize was there. And so I think as we start thinking about deep phenotyping, there are probably things that maybe a super seasoned clinician can pick up, but maybe even can't quantify. So how much time did the child spend in this eye contact behavior? What was the frequency or, you know, the hertz of the repetitive movement that they did that, you know, we can kind of subjectively quantify, but you can't objectively quantify unless you have those digital biomarkers. And so I love that train of thought. And I think that that's a huge area of opportunity. So kudos for the NODA team for also kind of getting into that space and starting to help kind of drive that forward. And I think Shefali Justi and the group that's doing the biomarker consortium, I think that's going to be really interesting as they collect that data moving forward.
Yeah. Great comments, Sharief. Your question, Stephen, also made me think that I kind of glossed over the opportunity. I think we're also missing as an industry the opportunities that when children come in for their diagnostic assessment in person, which you can't replace the amplitude of clinical data. Why aren't we doing what your everyday dental office does, and they take images of your dentition as you're kind of going through? We should be capturing that ADOS data. And we at Behavior Imaging have done ADOS data collection in one place and have integrated reliability look at the videos in another place in a fraction of the time. But if we take advantage of the clinical expertise that's tagging video in telehealth, but also using their clinical experience in person, having that data saved up into records that we can host for you all, the understanding of what behavior looks like in telehealth versus in person is going to be understood so much quicker, and many other learnings will happen. One other thing that I wanted to say, an application of NODA that happened accidentally is because of the limited time you all have when you see your families in person, many times it's coming up to, it's very gray when somebody goes through the instruments in the clinic for a short period of time to say what's clear. Well, some of our partners have prescribed NODA for families at that point to go home and collect additional behavior data to be able to get differential diagnoses much better from subsequent data they're receiving. So I want us all to think in terms of, we all in telemedicine, we all kind of know you don't replace the in-person experience, right? But if there are certain things that can be done as well, then why aren't we doing it? It saves costs, it saves access, it saves clinical burnout if it's done right. And we're very respectful for that as well. So just some other ideas about what these tools can help us do in the future.
And I'll just piggyback a little bit on that. I think Steve's point earlier about, you do have to be thoughtful about how you apply these things. And if you look at, again, some of the stuff that's out there, there is no single biomarker, there is no single test that's going to diagnose a child for autism. And it really needs to be the comprehensive looking at the whole picture of the child. And I think if we have tools that can help get that information to clinicians in an efficient way that gives them, as much information as possible, the better, is kind of my thought on this.
So Marcy, you have your video up. You want to ask a question?
So I think, like one larger question for me is because a lot of these things do pretty well at getting the right answer, but then the answer tells you nothing about what to do for the family, because we have a diagnosis that is like just unwieldy in terms of the heterogeneity. And I mean, even just based on age alone. And so, but there's so much like redundancy in these processes because we go through however many hours with a family, and then they get on the wait list for ABA or other treatments, and then somebody else does it again.
Yes.
And then, and like, it's just really inefficient. And I wonder if part of the problem, because like the comprehensive assessment, yes, it makes us more accurate, but ultimately what it does is it gives you a roadmap about what to do now, and like, can we uncouple the diagnostic, the classification or the answer from the assessment for the purposes of planning for the family? Because I don't know how to integrate these things in a way that ultimately actually increases efficiency, if that makes sense, if we're just doing things at multiple steps or phases, all, but those are my thoughts.
Summer, if I could just
go ahead, Ron.
If I could just give you a response to that, you've hit the nail on the head. Those of us families know after the diagnosis assessment, we get this report. the intervention folks start from scratch again to say, all right, what are the functional needs and where we can get there? I can picture a bridge to take the diagnostic assessment expertise and say, look at this place on the DSM-5 checklist of the child's inability to communicate this level, to the intervention folks to say, this is where you're starting from. And that would be, that much quicker to kind of come up with the intervention programs next moment, rather than starting the whole assessment process again for somebody's intervention plan. What does that mean? It's been a frustrating, thing for so many families, as I know everybody on this call can appreciate. Have you ever heard my wife talk about like what we need to do as far as a diagnostic record to what teachers could gain to say what we can do to start teaching them to what the diagnostic assessment record starts? You would know that this has been a sore point for so long,
Yeah, and I think similarly, you're right, Summer. The answer is important, but what fed and why is the answer there? And again, this is why we try and put all the information. So having all the inputs, what drove that diagnosis, making that visual to the practitioner, making it shareable, and then workflows are important. So for all of our tools that we bring in, the tool itself is important, but how do you actually use it in the real world? And I think that's why, we're trying to do projects where we look at real world use cases, what makes the most sense. And again, how do you also get clinicians potentially, if we're doing this, let's say we're getting pediatricians on board, how do we educate our, primary care colleagues, and it's probably not going to be every primary care physician, right? It's going to be, there are specialty programs to help train them up. They have to get comfortable, being able to diagnose and get some expertise in seeing kids with neurodevelopmental disorders. I'm hopeful though, I've seen in the residency programs and the medical students that I help train, we've seen, I think, a desire for them to be more engaged with neurodevelopmental disorders and not have sort of the, oh, you failed a screener, just automatic referral. They're being a little bit more, I think, excited about engaged and saying, okay, let me help work on this, and let me have a primary care medical home role in helping manage this child. Because unfortunately, I think the other big thing is again, if we rely solely on our specialists to come up with care plans to treat patients, right? We may be missing sort of like the GI play on autism, right? Or the sleep disturbance play in autism, right? And so I think having our primary care physicians help us, manage these kids and leveling them up is going to be what we really need to do long term.
Well, especially if there's an ongoing management, focus, because again, the answer is whatever is right now. And then we send families off into the abyss of the rest of their lives. But that doesn't, it's what do we need to do the next 3 to 6 months? And then after that, there's new stuff to work on, and there's new stuff, and there's new. So I like, if that's one of the goals, I think that's really cool. Yeah.
Let me go ahead, and we're about 2 minutes of the hour. And again, what I love about these talks is it engenders lots of conversation. Feel free to continue those on the listserv if you all want. So, I was intending for the next month to bring in a couple other like this. So we were thinking about STAT, Rita T, the rapid assessment screen device. They've already committed. There's the UK version of Helios, they call it, where they do an entire online assessment that they are now doing the same thing here in the US under a different name called Meliros. I forget the name of that. It's very different. And now the other one that you guys had already suggested would be really cool. So again, it's just, there's a lot of different kind of devices and tele approaches in this space that I think for our next month, we'll try to go ahead and have a couple of those come in again. And then we're going to move away from that for the next couple of months with some other topics that people are interested in as well. But these are really, really important conversations to have. Like I said, I think this is the future of where we're going and how do we integrate this stuff. There's a lot of innovation, a lot of new knowledge. So how does it change the real world for us, as you guys were talking about just then? It's like, how do we incorporate into our workflow? How do we ensure expertise? And again, for me, at the end of the day, is how do we ensure that we're supporting these families in a way that they need to be supported accurately and with everything they need to help their kids. So thank you all. Thank you, Cognoa team. Thank you, Ron, for coming and talking. Really, really appreciate it. Again, feel free to continue the conversation online if you guys want, and we will see you next month for Idea Next Month. Thanks, everybody. Have a good month.
Thank you.